everyone. Welcome back to the Mind the Gap podcast, a podcast where we speak with amazing people about how we can improve healthcare, but specifically for Black and Brown people. Today, I'm joined by the amazing Sarah, and we're going to be talking a lot about a variety of different topics. So before we get started, Sarah, could you introduce yourself to the listeners?
Absolutely. Thank you, Malone. So my name is Dr. Sarah Tade. I'm a GP registrar currently practicing in Essex, but I also have a special interest in healthcare inequalities, tackling that issue, in particular women's health, as we know that there are huge disparities within that particular sphere. I also sit on the RCGP faculty for Essex as the Equality, Diversity and Inclusion Representative. And I'm also a maternal health advisor for the NHS Race and Health Observatory. So alongside training to be a general practitioner, I'm very passionate about health promotion, health policy, and so forth. So I'm happy to be here.
A pleasure to have you here. It seems like you have a variety of different roles. I'd love if you could maybe touch upon your journey, almost like how you got into these roles and like almost like where did the journey of Dr. Sarah Tade start?
That's a very interesting question. So I would say my journey actually started with my love for the saxophone. On Instagram, I'm actually known as It's Dr. Sax because I love the fusion of music and medicine. And with that, I've done a lot of motivational speaking. I've always had a passion for health promotion, health empowerment. And I've genuinely just had an interest in healthcare inequalities, even though you can probably tell from my dialect that I'm from the south of England. I actually trained up north and I saw a lot of disparities in comparison to Liverpool and London. So that's what initially triggered my interest in having these particular disparities. Then I became a bit more interested in the work of Professor Marmot. I'm not sure if you know who he is, but he's a professor of epidemiology and also public health. And he released a review, and I think it was entitled the Marmot Review. And within that review, it was just talking about how social inequalities and social inequities are really a big cause to healthcare inequalities. And then that's when I started to get more interested in healthcare inequalities. Then we had the COVID pandemic, and we saw again the drastic inequalities that didn't just hit the general population, but we also saw the disparities in the amount of doctors that were dying who were Black and brown in comparison to white doctors. So we could see that this was not just about social class, because if you think about it, doctors are not at the bottom of the social class, but yet we still see these disparities. So that really intrigued me even more to be active in raising awareness about it. And I recently became a mother myself, and I didn't have a very good labor experience. It's one thing hearing about the statistics, and it's one thing when you experience it yourself. So again, this fueled my determination to be involved in trying to be part of the solution. We can always talk about the problem, but if we're only talking about the problem, then where is the change? And I think what is quite heartening is that there are campaigns, organizations, driving forces to try and change these disparities. So that's a quick synopsis of where I am up to now.
Because I love the point that you mentioned about the solution, the motivating factor behind these conversations, behind people being able to listen to these conversations works for this podcast to exist as a solution, as opposed to us spending so much time highlighting the problem. But I think sometimes we actually do have to touch upon the problem that exists for the solution to make sense.
Absolutely.
And one of the problems that you mentioned was some of your own personal experiences with maternal childbirth, and also just generally speaking, like maternal health in the United Kingdom and across the world. Do you potentially enlighten us? Maybe if you're comfortable enough to speak about your own experience, generally about the experience that other women, Black women particularly, are facing.
Absolutely. Yeah, no, I don't mind sharing briefly about my own personal experience. And that's one of the reasons why I wanted to join you on this podcast, because I knew it was solution based. And what I didn't mention earlier, actually, I'm also a certified life coach. And it's so important to be able to channel your goals, your action plan into the right space. Otherwise, you can always just be completely bogged down with problems and no solution. So I do think that that's one of the main driving forces to actually be a testimony to why I'm actually here and part of the solution as well. With regards to my own personal experience, I'll try and make it quite succinct, but to cut a long story short, I attended hospital because I needed to have an induction. There was a clinical indication for me to have an induction. But I had ended up progressing into labor spontaneously without the medical interventions. That's what the issue was. So when I had progressed into labor, the midwife that was attending to my care, she didn't take my concern seriously because I had explained to her I'm in pain. These pains are coming in waves. It's feeling like contractions. I need to have an examination of my cervix. I need to have my birth plan followed, which part of my birth plan was to have an epidural. She refused to examine me. She refused to confirm how far I had progressed into labor. She refused to acknowledge that I was in pain. She did not examine my abdomen. She did not look at my cervix. She just said, I haven't established that you're in labor, which is impossible to do just by at the end of bed inspection. So my situation of being in pain, in labor pain, was completely dismissed. In fact, it was attributed to my bladder being full. And she told me to get up and go to the toilet. And I can say this retrospectively, but at that time, because I've made a complaint and had my medical notes back, but at that time, my cervix was quite dilated. So could have ended up pushing my son into the toilet. There was just a lot of resistance. And at that point, she didn't know that I was a medical doctor. But this is my point. It shouldn't matter because the care that you deliver should not be dependent on the social class of the patient. And I was becoming to get increasingly worried. Yes, I had my own medical background, but I was a patient. So I trusted her. And it was only when things were getting quite out of hand, my waters had broken. I then again raised that to her. She completely dismissed it and said, oh, it's just moisture. Now, this is where my medical background kicked in because I said, well, my waters have broken. I could be at risk of infection if the right protocol is not put into place to assist me with my labor journey. So I actually highlighted to her that I'm a medical doctor. Her whole behavior, her whole demeanor changed. Then she examined me, was looking at the CTG, realized how dilated my cervix was, and everything just started escalating. Said she's saying that I can't have my epidural, it's too late. But still at that time, I had no pain relief, not even paracetamol in my system. I realized I didn't want my husband to miss the birth of our son because there were restrictions. He couldn't come in at the time because of COVID. And I said, please, can you call my husband? There was no assistance to do that. So I had to use my mobile phone whilst I'm in labor to call him. Otherwise, he would have missed the delivery of my son. Then she overheard me on the phone and said, oh, well, don't push because if you start pushing, your husband's going to miss the delivery. So she was gaslighting me that the problem was my fault. I was rushed to the labor ward. I was in distress. She was telling me not to push. So therefore, the quality of my pushing wasn't great. But of course, I have to push when there's contractions. So what ended up happening because of my distress, my baby went into distress. And then I needed an episiotomy, ended up having a hemorrhage. The medical team had to come to sustain my blood pressure and treat it as a medical emergency. And essentially, there was just a sequence of failing. And it's because I wasn't listened to, because I wasn't believed. It's because I was dismissed.
It makes you think in these situations that like something like you highlighting the fact that you're a medical doctor is what it took to get the escalation. In the case of somebody not being a medical doctor or somebody not having that medical knowledge or medical know-how or someone to advocate for them, potentially things like that could end in a completely different way.
Absolutely. And I feel that that's what is worrying. Because generally in the UK, especially when we look at the NHS, pregnancy and labor is safe. It's when we look at the complication, that's where the disparities lie. So when we look at mortality, morbidity within the pregnancy period, within the labor period, within the postnatal period, up to 6 weeks, that's where we're seeing these troubling statistics, whereby when we're comparing the mortality rate with Black women and white women, Black women now are still up to nearly 4 times more likely to die in pregnancy and labor in comparison to white women. I think the new data, it's Asian women is being 2 times more likely to die than white women. And this is just absolutely unacceptable. I feel that people being sized up by their gender, by their ethnicity, of how should we take you seriously. There's a structural inequality and it's a social injustice. And that is why I would definitely encourage, in terms of now the solution, is speaking up, write that complaint. I know it's not easy. You don't have to do it this first day you come out of hospital, but, keep a note of what's happened to you, write that complaint, write to your MP. It's only when we start doing these actions that we're going to start to see change.
Yeah. And when you say we, like, whose problem is this to solve? Is it a problem of us in the community that we need to solve problems for our community? Or is this a problem which society in general needs to solve as it is a societal issue?
Absolutely, because it can't just be down to the Black community because we're not the ones who's causing the problem. When we look at what the problem is, time and time again, it's being reinforced with structural and social inequality. Yes, we know that there are certain things that can complicate pregnancy and labor, such as high blood pressure or type 2 diabetes. But when we look closely, it does not fully explain the disparities in maternal mortality. So the problem is the system, the problem is the structural inequalities. And we can even if you remove race for a moment, there is a clear link between lower social-economic class and the greater risk of health condition. And again, just honing in on what Professor Marmot's review, the 2010 Marmot review, found that health inequalities is a result from social inequality. So this is not something that the Black community on their own can solve at all. This is a concern and it's a priority for our government. So as back to answering your question, it's everyone's problem, and therefore everybody has a role to play in the solution.
I remember reading an article actually, which was just an opinion-based piece. And the title of the article was will increasing wealth of certain individuals as a result, will that get rid of or reduce health inequalities in their communities? And the article was essentially arguing that if we had, for instance, Black Americans with a higher sense of wealth in the community, as a result, all of those social determinants of health, would they be gone? And then as a result, would the healthcare of that community improve? I read that article and thought it was an interesting take on improving health inequalities. However, I still kind of sit on the fence on what my opinion is on that. I just wanted to find out, like, what is your opinion on that? Since it's something which maybe people don't really talk about when we're talking about actually improving health inequalities.
I mean, you can't argue that poverty does bring worse health outcomes. But what we have to understand, in particular with the data and the statistics that we're looking at, is that the Black women who are subject to the disparities are not all poor. So, for example, 5 Times More released a report, I think it was last year, where they captured the voice of Black women regarding their maternity experience. My experience was poor, and I wouldn't be classed as somebody who's from a lower socioeconomic class. When I look at the data and you look at the women the voices that were captured, you had people who were earning over 100K that were a part of the pool sample, and they had terrible experience. So it's not just, if you're poor, the health outcomes are going to be horrible. If you're rich, all your problems go away. Because we're still seeing inequalities with highly educated, highly financially stable Black women, and they're still experiencing adverse outcomes. So whilst in part it can have a role to play, it's not the only factor.
Yeah, and I think it's a lot of the time we see these things, even when we look at this week in the news, for instance. One of the ladies who was in the Team USA relay team unfortunately passed away due to complications in childbirth. And we look at other notable figures such as Serena Williams, and it always makes you think that this is, like you said, a societal problem where every single person in society, no matter where you sit on the socioeconomic ladder, is being affected by the same problem. And I know one of the solutions which has kind of been developed in the UK has been the race the Race Observatory by the NHS, which you mentioned that you're a board member for. What is the work that is going on there, and what is the NHS Race Observatory for those who don't know?
So, what I would like to say is by saying what the NHS Race and Health Observatory is not. So, it's not just another team that's just going to be throwing out statistics. It's not just another team that's just going to be looking at short-term solutions. With the NHS Race and Health Observatory, the initiatives are to advise and facilitate action through policy change and research. So there's ongoing research at the moment that's happening that's looking to change quite a few disparities, especially within the neonatal sphere. So that is what I love about the observatory. It's health policy recommendations for long-term change. So it's not just a group where we're throwing out more statistics. It's, okay, this is the data, this is the information, these are the disparities. How are we going to change healthcare policy? This is how we're going to change it to result in long-term change. So I guess that's the simplest way that I can put it.
And when we talk about healthcare data, this is actually one of my favorite topics, just because of how complicated yet simple it is. When we talk about doing research and healthcare data for minority communities who are being affected by health inequalities, what are some of the challenges that we are facing? One of the challenges that I know of is sometimes when you look at the data and you look at the experience of the community, they're two different things, because people will happily tell you, if you go out and stand on Brixton Market, their experience of healthcare. However, the people who are coming to fill out the data for us to get the information, for instance, at a hospital level, at a research level, sometimes there's a massive disconnect between the two. So we might have data which says actually the experience is not that bad. Whereas if you just speak to people, lay people in the community, they will tell you like far worse. Like, what, from your perspective of dealing with almost or seeing that data, what is going on with the data?
Are you talking about data within the Black maternal health, particularly, or just data in general?
Just generic data when it comes to dealing with health inequalities.
That's an interesting question, actually, which I wouldn't say I know the definitive answer, because off the top of my head, I don't know what the numbers are in terms of the ethnic breakdown of participants involved in research studies. However, what I can say is I know that 5 times more, they, as I mentioned earlier, they released a report, the Black Maternal Experience, where they literally captured not just quantitative data, but also qualitative data about disparity. And for example, some of the quotes were a little bit distressing. So in the report in 2022, one Black woman had said that the first visit, a nurse said she was shocked I knew who the father was, as people like me usually don't know. Another comment in the report was, I'd turn up in a tracksuit and be spoken to in a certain dismissive way until they learned I was a lawyer, and they would be more respectful overall in my experience. Another comment from a participant in their study said, there was a sense that the midwives felt I could handle the pain. I was left alone to give birth to my baby in the toilet. She fell into the loo on my last push. The midwife didn't check on me for hours. So, I mean, what did these comments show? An assumption of a lack of family structure, that respect should be conditional to educational status, and that pain management is not a priority for Black women. So, I mean, when we look at that, that's not really exciting. It's worrying when you're hearing these things. So I feel like it's a good point that you've made, actually, because I think that's the first of its kind, that report literally capturing the voices of the community. But in terms of what is that, how is that reflected in other research, I'm not quite sure in terms of the numbers. But again, I guess we could flip the question and say how many people within the Black community are getting involved with research, are getting involved with clinical trials. And we know that there's historical reservation when we look at scandalous trials like the Tuskegee experiment in America, the meningitis trial scandal in Nigeria in the 90s. So we can understand why people are hesitant to get involved. But what I would say is that the research ethics committee has evolved drastically, and there are policies in place to protect the interests of participants who do get involved in clinical trials. So on one hand, you could say, oh, are we being deliberately excluded? But on the other hand, you could say, well, are we actually actively wanting to get involved?
That's what I've noticed. The study that Five Times More puts out, I think the reason why people could almost get to that level of sharing their experiences was because Five Times More exists as a body, as a community, as an organization, which Black women can trust. And I think I noticed that through building our company, Black and Brown Skin. Sometimes people would share so much information with us about their experiences at various hospitals across the country. However, if you go and look at the patient experience report for that hospital, it would almost read as there is no problem. But I have loads of anecdotal stories from members of the community, which are saying the complete opposite.
Absolutely.
So that was what I was alluding to in the question before, to say, are we necessarily not going to share our experience because we don't have an experience? And when people are doing research, they could look at the patient report survey at X hospital and be like, from this data that we have, there is not really that much of a problem. Or they can go and research the data that Five Times More are collecting, some of the information that we had collected in the past, and say, actually, like, this is like a code red, like we need to do something right now. And on the topic of like, we need to do something right now, if we look forward, let's say 10 years from now, what is the, if we can sit down, maybe me and you, and devise a roadmap that we know that this conversation exists and it's been happening for so long, but in 10 years from now, we don't necessarily want to be having the same
No.
conversation. Can we do things, or what needs to be done for us to basically not need to have this conversation again?
Well, I think definitely just people, even just being aware. So, what we're doing now, raising awareness, is really important. If you're unaware of what the problem is, you just end up getting entangled in it yourself. So, I'll definitely say raising awareness. Number two, I would say being an advocate for yourself. It's not always easy, and people don't always feel that they can speak up for a number of reasons. There may be barriers with communication, and I don't necessarily mean English not being your first language, just that the dynamics of a shift of the power status. When you're the patient, you're at the mercy of the clinician, and that may make you feel a bit intimidated to be an advocate for yourself, or even just knowing what the system is. So, for example, how to make a complaint. Are you aware of PALS? Are you aware of protecting your own mental health if you have had a bad experience? About postnatal mental health support groups, for example, or even if the problem may not be maternal health, for example, just knowing how to access your GP for certain things. People may be unaware of the support groups, the counseling groups, the cognitive behavioral therapy. There's so many different facilities out there to help to promote your health, but are we aware of it? Are we aware of the impact of our own physical inaction? So a lack of exercise. I don't mean running a marathon. I mean just even physical exercise of 60 minutes a week. How that can improve your mental health, your physical health, how that can decrease your risk of so many diseases. Are we having these conversations? So I hope that helps to answer a little bit of the question that you asked. But on a bigger picture, I say now, if we're thinking about what can powers that be do, like the government, NHS, for example, what they realized is that we need to improve continuity of care. This is in reflection to tackling the maternal disparity. So, for example, if the midwife that delivered my son was the same midwife that I had throughout my antenatal period, there wouldn't have been that problem because there already would have been that connection and that bond. So having the same midwife or clinical team providing the care for a woman and her baby throughout pregnancy, labor, and after birth, that enables this aim for the woman and her responsible clinician to develop a relationship over time and therefore be more likely to have individualized care. That was one of the things that the professor who pioneered the Embrace report, Professor Marion Knight, what she had noted was when it came to ethnic minority women, they were less likely to have that individualized care. And what I would say is good is that there is an action plan, there is a target. And NHS England, for example, I believe are aware of this target that by 2024, 75% of women from the Black and Asian, Asian, communities, and essentially the minority ethnic community. I don't like saying the word "bay." That's why I like to just spell it out. So that they can receive continuity of care from their midwife throughout pregnancy, labor, and the postnatal period. And what I like about that is that there's a date and there's a specific figure. So 2024, 75% of Black and Asian and other ethnic minority women should be having that continuity of care from their midwife. So that enables accountability. So there's a target to reach and a time scale. So there's a measurable aim. I think that's great. And again, in relation to maternity, there's the disparities task force as well. So you have experts from key stakeholder positions like chief midwifery officers, ministers for patient safety and primary care, all coming together to make key recommendations that can influence policy and result in change. It has been recognized by midwives in very high positions, by the NHS, especially those who work in healthcare inequalities, that if we increase the number of ethnic minority clinicians in leadership positions, especially within maternal health, then we can help to sort of shift these disparities. Because one of the problems is that there is a lack of representation in senior positions and there are barriers to career progression. And I think what is encouraging is that this is being recognized as a need to address. So I think that that's good as well.
Yeah, and I think it's sometimes referred to as like the snowy white peaks, to say that the further you climb up in the NHS, the less diversity that you see.
Yeah.
And it's something which loads of people have talked about in the past. And it's great to see, like from the time that I started doing this work in 2020 to now, that there is a few faces and a few people who are breaking through those molds and almost trailblazing for hopefully the rest of us behind them. And almost kind of to flip the script a little bit, I wanted to find out as well, like, what do you think we are doing wrong in this space? Or when we talk about improving the future and improving healthcare for our communities, is there something that you fundamentally think that this is the wrong approach to us solving the problem, but it's something which people seem to be talking about all the time, or people seem to be doing over and over again, almost like making the same mistake 1,000 times?
That's an interesting question. That's very, very broad. If I was to just narrow it down a little bit, there was some data that I became aware of. There's a women's health company called Fertility, and they released some data about inequalities again. And what it said was when they looked at the pool of women that approached their platform, so again, their platform is Women's Health Fertility Assistant. Their data showed that in comparison to white women, Black women were presenting up to 5 years later seeking for help for fertility. So that is a problem. Why is it that when it comes to seeking for assistance with fertility, Black women are presenting so late? Is it due to, poor experiences in the past? Or could we say culturally, do we have a little bit of a problem about being open? For example, my background is being a Christian. I know just because you're Black or brown, it doesn't mean you're Christian. You may not have any faith, maybe Muslim, maybe British, maybe Hindu. But if I just draw upon my experiences from a Christian background, there's a lot of the times people may be going through struggle. And there are a lot of cliche responses that I'll just pray about it. And don't get me wrong, there is nothing wrong with praying. Prayer, I believe, as someone who's a Christian, is very powerful. But also faith without works is dead. So why not push forward to get the help that you need? And sometimes there's this over spiritualization of, if you're calling the doctor, you don't have faith in God, which is just nonsense. Because if we even look at the disciples, Luke was a physician. So personally, from what I've seen, I think that's an issue whereby people are almost looked down upon oh no, you don't need to go to your doctor. You can just come and pray about it and all your problems will go away. And it's getting the balance right. We are not just spiritual beings. So whilst spiritual health is essential, it's very important, we are also physical beings. And there are physical needs that we need to address. And there are solutions. So personally, I feel that that might be a little bit of a problem, not being very open, feeling discouraged to ask for help. Or again, it could be a reflection of structural barriers, being dismissed earlier and at an initial presentation, and then not wanting to come back. So if I was to summarize what I feel can be a problem, I would say not being open, not seeking for help. And we see these disparities with mental health as well. You know, being criticized if you say you're depressed, if for example, if you say you're suicidal, being looked at as if you're strange. So I think that these behaviors can be huge barriers to getting the help that we need. So the solution to that problem is ignore the negative aspects of the culture, whereby people want you to sit and suffer in silence, and go out and seek for help. That's what I would say.
And how do we decipher what is a negative aspect of culture? Because one person could be saying there and argue to say that actually that part of my culture is not negative, whereas we might be saying on the other side of the table saying actually it's not maybe the best way to deal with an issue. And maybe to give an example, maybe if we just touch upon the intersection of healthcare and religion, someone might argue and say that me going to pray about God for better health is not a negative aspect of religion, but we might say on the other side of the table to say, again, faith without works is dead. So how does someone decide for what is the negative aspect versus what is almost the good aspect?
Yeah, I mean, it's wisdom, because at no point in time is anyone saying if you pray, that's a problem. When you look at people who actually have better health outcomes, and this is not even just Christian, people who pray or who meditate tend to do better in terms of recovery from certain conditions. That data is widely supported. So essentially what I'm saying is, if you have a problem, of course you can pray about it. Of course you can meditate, but that should not stop you from also seeking help. I don't think the two should be separated. That's my point. Yes, you can continue to pray. Yes, you continue to have your faith, but that doesn't mean you can't seek for help. And in seeking for help doesn't mean you should stop praying. I feel that the two doesn't have to be separate. They work very well together, to be honest, because a lot of the times when you are going through a journey, for example, if somebody needs to go through IVF, that can be a journey that can induce a lot of anxiety. And I believe that praying alongside that journey would be very helpful, for example. So in answer to your question, what can be perceived as something that's negative is something whereby you see the result is unhelpful. So if you're not getting the help that you need and your condition is deteriorating, then that's not positive, is it? If you're suffering with your mental health, but you're afraid that people say, oh, you're not allowed to be depressed, you're not allowed to, be anxious, then that is negative, because people can be depressed, people can be anxious, and they should be allowed to get the help that they need. So I would say anything that is just where your own opinion tells you how to act, or people's own opinion tells you how to act, because there's nowhere in the Bible where it says you can't go to the doctor. It doesn't say that. But it's people's own opinions that dictate how people should behave. I would say that's what can be harmful.
And I think one of the things which is that kind of ran through my head while you were talking about that is this very nicely intertwines with almost perceptions that generally speaking, Black men have when it comes to seeking out help, when it comes to mental health. And then when you couple that with the rates at which Black men are being sectioned, the rates at which, just generally speaking, loneliness amongst men is rising, all because of this perception that be strong, be a man, be a guy, have in society. And it's, again, have wisdom to be able to decipher the good parts and the bad parts of the culture. And just before we end, we have a tradition on this podcast where I ask every single guest one question. And that question is, if you could improve healthcare for your community, what would you do? And before you answer your question, could you define who your community is?
That's a good question. So I would say if there's not just one answer of who my community is, because I guess as a general practitioner, my community will be the community that I serve in terms of my local population. So I guess it just depends what hat I'm wearing. So then I guess in terms of tackling healthcare inequalities, my community would be those who are suffering with healthcare inequalities. And that's not just a race thing. We see issues with gypsies, with travelers, for example, with people with mental health issues and so forth. So I would just say, I would say a message that will relate to every one of the communities that I serve. And that is be an advocate for your own health. So if you know that you need something, push for it. If someone tells you no, you are entitled to a second opinion. A lot of people don't know that. They feel that if they hear one opinion, that's it. And that's gospel. That's not the case. You can get a second opinion. So be an advocate for yourself and take care of yourself. So try and create some time to rest. Make sure that you prioritize exercise. Doesn't mean go to the gym. I actually don't go to the gym. I go for jogging and I do home workout. I don't have the time to go to the gym. So yeah, prioritize your physical health and prioritize your spiritual health. That doesn't mean that you necessarily have to believe in God. Your spiritual health is, where do you get your strength from? What are the things that you need to lean upon to build you up? So those are the things I would say prioritize.
Well, thank you so much for being a guest on our podcast today. I'm sure everybody listening gained a lot of wisdom. And I'm hoping that this is a conversation that we can look back on in a few years and be like, this was a turning point for someone. This was the conversation that someone took something away and changed essentially their health or changed health inequalities for a particular group of people. So thank you so much, Sarah.